We are delighted today to have, once again, Dr. Kyle Colvett, and who is going to come here momentarily. But before that, I would like to recognize the family that sponsors these lectures, and that is Nancy and Calvin Rose. Can you please stand up? If you can just stand up for us to see who you are. Thank you. The generous gift is in honor of their parents, and they'll continue to fund these lectures. They have also funded the faculty lunch on Tuesday, and they are also funding the luncheon today, so please don't miss that. Now, Dr. Colvett gave lectures here on Thursday. The first one was metaphor and medicine. I couldn't help going through the library, and every time I look at a book, I think of these metaphors, what it represents. And there was a book that I saw entitled Battling Hunger. And I said, well, it's quite a battle. And yesterday he gave a lecture on worthless physicians. And I can tell you that Dr. Colvett is not one of those. Dr. Colvett is a professor, preacher of the gospel, a physician, a scholar, and he's engaged us since Tuesday. These lectures are given at a time when our world is threatened by horrible forces, ISIS in the Middle East, Boko Haram in Nigeria, and above all, Ebola. There are other life-threatening diseases in which friends at the medical center are familiar with, and we are so grateful for their comfort and their healing hand. But in response to such horrors, Dr. Colvett does not tell us to retrieve or to persevere until Jesus returns to take us to heaven. Instead, he points us to the gospel that a vision of a different world is possible within this world, in which a piece of God's shalom is enacted and brokenness is repaired through acts of care, love, forgiveness, reconciliation, and healing, where the good news is preached to the poor, prisoners freed, the oppressed released, the blind see, and the year of God's favor is proclaimed. Let us pray. We thank you, God, for the hope that you give us in the gospel. We thank you for your servants, particularly Dr. Colvett, who you've gifted to serve in the medical world and bring about comfort and healing. And not only that, he continues to proclaim the good news. May you bless his ministry, his family, and his work in a broken world. Now we receive him, O God, in your name, that he comes to share with us that which you have given him. In Jesus' name, amen. Dr. Colvett.
Thank you, Kid. Good morning. Thank you once again to the faculty at Emmanuel for the kindness of the invitation and your support. I'm delighted to see people from several different communities within our region. I see the ministry scholarly community here. I see medical folk here. I see people from town, and with that idea, the circles that we run in begin to intersect in individuals, and it's my hope through what small contribution I might make in the lectureships, that we'll have those circles intersect more and more, that there'll be people who understand the relationship between these critical areas in our lives. So I'm delighted to be some small part in that, and I'm grateful for the invitation. So on Tuesday, we talked a bit about the idea of metaphor, a bit of a historical survey, and a look at how we communicate, both in ministry settings and in medical settings, and how we might better do that by having our ears attuned to the words we use and how we communicate those things. Last night was a bit more sermon style. That was an idea from the book of Job, but commentary that people throughout history have struggled with these questions of God's justice and goodness in times of suffering, and with the recognition that that story is eternally true. It's a universal story for us, and we hope that we can communicate that the struggle and the uncertainty and the doubt and even the anger with God are healthy and productive means of working out faith. They're not the antithesis of faith, but a part of faith working itself out. And so we hope that we would be a community of people tolerant to doubters, tolerant to people who are uncertain, and welcoming of the challenge. We all try to seek and understand the eternal and the nature of God. Today's a little different. It is, on the surface, a talk that sounds like a technical, wonky kind of approach to the understandings of how we view medicine, but I hope you'll see that that's merely the door toward a broader discussion and application. And so today the question we ask is should we consider adding a spiritual health axis to the biopsychosocial model? And so we'll explain those things along the way, help you understand why that's a question to ask, and at least tackle some angles at how we might answer it together. The biopsychosocial model is a framework. It is a conceptual model of health and illness and wellness that takes the dynamics that are inherent in the name, that health is related to biology, psychology, social factors, and together those play a significant role in human functioning. So diagrammatically, we might see that as those realms of social and biological and psychological intersecting with a person in their health. This model sort of came about in the 1970s. Professor George Engel at Rochester wrote in a very scathing editorial and later article in the journal Science that our approach to medicine and health was missing a number of important dynamics, that it was not a model that was best in terms of understanding health, promoting health, and how we use our resources and how we approach the problems that we see. And so he didn't name this, but it became named the biopsychosocial model and has been associated with him ever since. So in this model, health is best understood as a combination of factors. That it's not merely the laboratory test or the chemical abnormalities in the blood or the DNA, but it's the person's mind and mindset and the social milieu that they find themselves in. And so it's in contrast to what had been the standard model that in retrospect has been called a biomedical model. Prior to this, it was just medicine. It didn't have a special name because there wasn't a contrast or comparison. It was only in contrast to some ancient, less scientific way of viewing things. And so medicine and science were entwined, but now we consider this the biomedical model. Now, the biomedical model says that every disease process can be explained in some underlying deviation from normal function, an injury, an infection, a poisoning, something toxicity, gene function, developmental abnormality. So everything's got a pathophysiological explanation for why it happens, and this model has stood us quite well. So one of the main reasons that our life expectancy is on the order of 40 or 50 years longer than it was before modern medicine took place is that this model says there's an explanation for this. It was not evil humors that floated from the swamps that gave us malaria, bad air, but actually a plasmodium that gave us malaria, and now we'll treat that. So there wasn't some unusual influence, an influenza that floated through the ethers, but actually a virus that caused that. And we approach those diseases with a cause and effect and an intervention model. So this is the critical step that's given us the advances we've seen in medicine. And anything we say today is not in criticism of that to say that that's outmoded. And in fact, I'll have some pointed comments about people who have dismissed this approach. But it is a model that has gaps. It is a model that doesn't see the full picture. So there's a normal state, and something happens to us, and there's a disabled state, an illness that grows from that. And so we do something. We remove an infected organ, or we provide a medication, or whatever the intervention is, and then we're back to the normal state again. That's the core structure in its simplest terms and distilled idea of what the biomedical model is. The emphasis is on medical treatment. It's a binary kind of concept. You're either healthy or you're not, and if you're not, we've got to do something about it. And that's not always the best approach, as we'll see, that there is a spectrum of health and function. And very few of us are ironclad, absolutely, without any exception, healthy. But by saying anything that deviates from that is wrong, we end up treating lots of things that may not really need to be treated. They're the normal variations. And we end up labeling variations as diseases when maybe another way would be better. But more importantly than that, I believe, is that it's missing important dimensions of health. In the biomedical model, psychology and social things are remote. They're in another town. They're down the road from the biological considerations. And it may address the disease, but it doesn't consider the quality of life in the individual. And as we'll see most critically, I believe, that it neglects a spiritual component to health that many of us in the room would agree is important in picturing the person as a whole. So in contrast, the biopsychosocial model that was proposed by Engel and those who followed him realized that all of these factors are intertwined and interlaced in ways that aren't quite so clean, that health and illness are influenced by many factors, that body and mind are not separate, and that relationships are significant to health. And those relationships between individuals and their community, between individuals and their country and their government, between doctor and patient, all of those have important dynamics to consider. So it's not quite so easy as the operation is on Tuesday, or here's a prescription to fix your problem. And it's also important, as we said, that health should be seen as a continuum, and it's harder to label normal and abnormal on a continuum. It's much easier on a binary. It's an on or off switch. The implications of the biopsychosocial model are that it considers all of those factors in the big picture and allows things like preventative health care to be considered. So someone is healthy. In the biomedical model, you're healthy. We don't need to intervene. But in the preventative model, it allows us to say things could happen. We need to be in concept of that lifelong approach. It allows adaptive health care. There are things we can't fix, but things that we might make better or ameliorate or palliate. And it allows values-seated health care a more prominent position. What's important to the patient? What's important in their life and their lifestyle? And in this case, we see that relationships are significant to health. Patient and doctor, patient and family, patient and friends, patient and faith community. It's going to be a little small to see, but the realms are complex. And rather than being discrete entities, they begin to intersect. And I want to show you a clinical circumstance of how they intersect. In this case, we see mental health, but it might have aspects of the person's psychology, but also their genetics and their social circumstances. That it's not merely just this is a disease that we can give a label from the DSM, but realizing that there are complex things that feed into that. The biopsychosocial model is a paradigm for it's sort of the technical term for what's typically called the mind-body connection. And so most research and publications, however, have shown that this is a philosophically attractive model, but it hasn't been tested in any kind of rigorous way. Most of us would agree. It's almost self-evident that psychological things affect our approach to health and that social things are having an impact. And so the model has validity just on its face. It sounds like the right thing, but it hasn't been tested. It hasn't been compared to say, is it superior to the biomedical model? In other words, is awareness that we're missing things to be equated with doing things better? And so the model validation has been treated as self-evident rather than testable, and it may be hard to test. But with that, some criticism has come. So rather than saying now we've got the best model of all of looking at health, some people have pointed out some things about this model. Tavakoli says that it promotes an artificial distinction between biology and psychology. And the more we learn about brain and brain chemistry, it becomes very hard to draw a line as to what's a serotonin problem and what's a mood problem. And so what's a neurotransmitter deficit that might be partially genetic or environmental, and what's actually something about the cognition of that person. And so biopsychosocial model doesn't dismiss those, but it sometimes creates the idea that these realms are distinct when it's very hard to sometimes draw a line. Pilgrim said that what has happened when the biopsychosocial model was introduced in the 1970s is that we all said, yeah, that sounds good, and it promoted a sort of a mutual tolerance and coexistence of perspectives, but there hasn't been a real theoretical integration. No one quite knows what to do with it. And so we're still faced with a sick person in the office, and you may well realize that there are policy statements made in Washington, D.C. that have a trickle-down effect on the health of that person and their ability to access their medicines, but the intervention that you can provide is still one-to-one and a prescription pad in terms of that encounter. And so most of us tasked with the health care of someone is on a one-to-one basis, and we can't step back and make sweeping prescriptions for society as much as we wish we might. And so the model has some gaps in that sense. And McLaren said that psychiatrists embraced the model without any scholarly evaluation. They said, that's what we're doing now. And that was a criticism. Gamey said that the model, he thought it was anti-humanistic, that it really promoted a kind of a paternalism, like I, as the scientist or scholar, will assess the cultural situation. I understand your social situation, and I'm going to name it and describe it and categorize it. And I'm going to say, well, because you're in poverty, you're this, and because you're African American, you're this, and because you're... And so it becomes much more of a top-down organizing rather than a collaborative concept. And it can sometimes be seen as counter to the patient-medical partnership, that one that we hope to empower our patients to communicate back about what's important to them. And the model has some gaps in that regard. And then it became, no one intended this, but it became the euphemism for psychosomatic illness. And so someone comes in, we can't figure out what's wrong with them, but they're still sick and don't feel well. And we say, well, there's probably some biopsychosocial issues that are affecting the health of this person. It became sort of the critical byword for going, we don't know what's wrong with this guy, and we can't fix him. And so that's not a criticism of the model, but a criticism of the application and its utility in medicine. It does unintentionally give credence under the umbrella of mind-body medicine to a whole host of weird ideas. That once we've said that the mind and the body are intersecting and interacting, then people can come up with completely untested and untestable ideas and say, well, we're helping their health through the mind in a way that has created a new age approach to things that are completely and utterly scientifically implausible and impossible. And it allows, sort of gives a credence and license to all sorts of things to be entered in that are untested and untestable. And it erodes the progress we've made by saying this is better than that, we'll do this now, when it becomes very much the anecdote, the anything goes erosion of orthodoxy in science. But for our purposes, those criticisms are theoretical and academic, and we'll be aware of them. But in our discussion today, the biggest gap is it really doesn't address spiritual issues in any direct and immediate way. It will, in some publications, the model will acknowledge that psychology may have a spiritual dynamic, but it attributes all spiritual things to merely the mind's perception of those things. And without chasing too deep down a trail that gets us into how do we perceive anything and those kinds of navel-gazing ideas, that will say that many of us believe that psychology and spiritual are not synonymous, that there is a distinction there, and that spiritual ideas also envelop areas that we would consider social, that many of us work and act and believe in faith communities. And I believe, as an editorial statement, that God in His wisdom sent His Son to die to establish a church, not a series of millions of free agents. And in that sense, that our spiritual relationships are always in community and always in concern for those around us and in motivation and movement. And so spiritual things have a social dynamic, but our typical social assessment doesn't quite cover and understand that in the way we might wish. So, is it reasonable? Is it appropriate to modify the biopsychosocial model by adding a spiritual axis? So let's consider a clinical situation. Let's ask a question about it. In Tennessee, one of the biggest public health problems that we're seeing now is the rise of newborn babies born addicted to narcotics, born addicted to opioid medications, things like morphine and hydrocodone and medicines that you've heard about as pain medicines. So this graph shows the number of babies born in Tennessee, this is just our little state, from 1999 to the present, who are born with a diagnosis of neonatal abstinence syndrome or neonatal addiction syndrome. And so in 1999, there were 50 or so, and in 2014, we anticipate nearly 1,000 children in our state born addicted to these medicines. These little kids are born. They've been getting narcotics through the umbilical blood into their body throughout their prenatal development. And once they're born, they're taken away from the supply. And within a few hours of birth, they become horribly ill. It is something that is striking. The sound of the cry of a narcotic addicted child is very different from anything you hear from a newborn. They shake and have rigors. They have this horrible diarrhea that's hard to control, and the miserable children who can die quite quickly without intervention. At Johnson City Medical Center this morning, there are 9 of those babies in the neonatal intensive care unit. So this is a problem. Now, from a purely medical sense, we just need to support them, maybe support their breathing, actually sometimes provide them with narcotics and doses and taper them and wean them off in ways of helping them. It's a complicated story, but there are medical things we might do. But the story's bigger than that. It's not just the biology of that baby that's the concern. That's not the end of the medical textbook to say, how are we going to fix this? How do we take care of that baby? We're going to realize, well, how did the child get the opioids in the first place? Well, there was a pregnant woman taking drugs. This is a graph of Tennessee prescribed opioids per 100 people over a 5-year period, 2007 to 2011. The red line on top is women. So now we see that women in Tennessee are more than they're 1.5 times as likely to get a narcotic prescription or be receiving narcotics than men. That's an interesting question, and that number rises. When we look at those who are taking narcotics without a prescription, it's even a higher ratio. So something's afoot. Why are more women using narcotics than men in Tennessee, and why is our rate much higher than some other places in the country? We're now not talking about purely biology anymore. We're asking questions that are broader than that. In Tennessee, from that same 5-year period, there were 37 million opioid prescriptions written. Tennessee only has about 6 million people, by the way. So think about it for a minute. That in a 5-year period, every man, woman, and child had 6 prescriptions for opioids on the way the numbers work out. So 5.2 million people, 20,000 different providers, physicians and nurse practitioners and physician's assistants, 2,400 pharmacies. There's a lot of opioids being used. And so now the question becomes, wait a second. This is not merely the social situation of, bad women who are taking drugs. There's something about our society and our culture that's using a lot more opioids than they ought to. And by the way, these are the ones we know about. This is not the people who take a field trip to Florida and get some narcotics and bring them back. By the way, Florida is a really good place to get narcotics cheaply and quickly, by the way. It's the least regulated state of our 50. In that sense, it is the wild, wild west of medications. But we're seeing that there are now people who have the power of the pen to prescribe, who have an impact and a role on these little babies in the neonatal intensive care unit. Family doctors and surgeons and internists are now part of the story, and it's broader than biology and it's broader than sociology. Opioid prescription rates by county in Tennessee, the darker the shade, the higher the rate, and East Tennessee leads the way. My beloved county, Crockett County, is the white county in the middle of West Tennessee. And the reason that it's white is there are no doctors that practice there. So that's why we, there's one. There's plenty of people taking opioids. It's just the way we count things. There's just one pharmacy and things of that sort. But East Tennessee becomes things. So we start asking things about culture and geography. Is there something about Appalachian culture? If we were to see a national map of opioid rates, these little mountains from Pennsylvania down through North Georgia, that's the apex, the height of opioid use nationwide. So why is that? Is there a culture that's focusing on using pain medicines more than others? And so our model begins to just completely fall apart if we think of things in purely biomedical terms, because there's psychology involved in seeking drugs. There's the physicians and caregivers involved, and sometimes it's a lot easier to write a prescription for a pain medicine than to really delve into what's wrong. That there is a tendency in the Appalachian regions to do what's called somatization. It's a lot easier to not work because your back hurts than it is to work because you have anxiety or depression. And so the disability account is much more socially acceptable to say, well, I used to work in a factory, I used to be a farmer, but I hurt my back, and now I need to be on pain medicines. That's socially acceptable. But to say I couldn't cope with the worries of the world because I wasn't equipped to do that, you can't say that socially. And so we somaticize. We turn spiritual, psychological things into physical symptoms. And we treat them with physical interventions, but you can see quite quickly they're at cross purposes. So is the story of the babies at Johnson City Medical Center and Children's Hospital in Knoxville this morning a biological problem? Well, yeah, there's some really interesting and complex biology. By the way, those children are going to have lifelong higher risk of addiction. We are now seeing the third and fourth generation of addicted women giving birth to addicted daughters, giving birth to addicted daughters, giving birth to addicted daughters. Is it a biomedical problem? Yes. Is it a psychological problem? Well, yeah, sure there is. Is it a social problem? In 100 different ways, yes. Is it a spiritual problem? I'm going to tell you I think it is. It's not purely a spiritual problem. These aren't evil people. It's not sin, in a very explicit and narrow sense. But there is a spiritual dynamic to this problem and many other medical problems that we see. And if we ignore that, we do so at our peril. We do so at our peril as medical caregivers, but we do so at our peril as people concerned about the spiritual well-being of a church that you may have pastoral responsibility for, or a faith congregation that you belong to. And to ignore these is to be missing the point on what we ought to do. So, should we have something like this, a bio-psycho-spiritual model that's worth 300 points in Scrabble if you can get the letters together? And we don't have a better name for it yet. And almost every name we might consider using has already been co-opted by some sort of strange concept. And so that's what we're stuck with right now. And if someone has a better idea, please let me know. So it takes into account a rigorous scientific view of pathophysiology. That's real. DNA is real. It's not imaginary. There are genetic syndromes, and there are physical problems with blood vessels, and there are things that really happen. But it has a respect for the psychological, and that's real too. And it has a perception and awareness of the social environment, and to be engaged and concerned about the health of individuals We must be engaged and concerned about those things in society that affect people's health. So health, wellness, suffering, and justice are intertwined in ways that they can't be separated and parsed about. And so we need to have an attention to the spiritual distress and the spiritual resources of the people we take care of. This is critical. Tournier said the patient is not just body and mind, but a spiritual being. I think we all affirm that. The fact that you're here today means you believe that. And spirituality involves, at least in one definition, the personal quest for meaning and purpose in life as it relates to the inner essence of the self. This is more than just psychology. Meaning and purpose are transcendent ideas beyond the immediacy of the individual in their life. And so spirituality in one definition might be the sense of harmonious interconnectedness with self, others, nature, and an ultimate other, that integrating factor. For people of faith communities, the ultimate other has a different name. That's our Creator. That's God. This is not a new idea. In ancient Israel, the most fundamental prayer, the Shema, to hear Israel. The Lord your God is one, and you should love the Lord your God with heart, soul, mind, and strength, at least in one formulation of that. And so in ancient Israel, a relationship with God was not merely heart language, but it was body language and social language, all of Israel to be called to this. And I believe that worship is mind, body, spirit. I believe that health needs to take in concept these as well. So if we had a model of social and biological and spiritual and behavioral things, how would we use it? And have we just come up with another model that's not that helpful? In other words, why not consider a spiritual aspect to the health model? Well, on one hand, religion is sometimes seen by a lot of people, good people, well-intentioned people, as an impediment to medicine. It gets in the way. We've got something we can do to fix this nice person who's a Jehovah's Witness and needs a blood transfusion to stay alive, but they've got this crazy idea that they can't have blood transfusions, and so their belief system is interfering with us from fixing them. We're fixers, and we can't fix them because of their belief system. Or there's a person who has a health problem, and they've chosen to go through a Christian Science healing phenomenon that's been present in the United States and other places in the world. And sometimes that means they avoid, it's not entirely true, but they often avoid traditional health things. And we've got something we can fix that, but they're choosing another route. So it's an impediment to medicine. End-of-life decisions regarding assisted suicide. All of these ethical dilemmas that we hear in the newspapers about life and death and birth and prenatal health and these kinds of things. And it starts to have a social dimension. Should the federal government require a faith-based hospital to provide health care for the female members in their insured group that requires different forms of contraception? So you know what? This religion and faith stuff is just getting in the way. And if we start integrating it into things, it's going to impede us at every step. So maybe we shouldn't include spiritual. Let's pretend it doesn't exist. Life is simpler. There's also the idea of the staggering diversity of religions and religious beliefs. Even in our little part of the world, there is significant cultural diversity and religious diversity among the people that we come in contact with, the people in our hospitals and in the hospital beds. And I told some of the students yesterday, please don't assume that you know how someone believes based on which box they checked when they came into the hospital. Says, oh, I see you're a Free Will Baptist and you know exactly what they believe. Don't assume it. And if you're in a pastoral or preaching situation, don't assume that the people in your pews have read the creedal statements and know how the world works and how you believe about things like free will and God's will and health and failing and things of this sort. I have a word I've created. I like to create words. It's a neologism, and you're free to use it. You can send me a nickel every time you use it. And that word is idiosyncratic, not idiosyncratic, that people's belief system is idiosyncratic, it's unique to them, but it's also syncretic. They've picked and chosen ideas from all kinds of different religions and patched it into their own unique way of how the world works. And no two people are quite alike. Two people in the same family, two people in the same church, And so they're idiosyncratic. Now, your spell check is going to correct it every time you try to use it. People are going to think you're not terribly well informed because you spelled a good word wrong. But if you do use it and get away with it, 5 cents, please. So this syncretism means that people who are nominally Christian may actually have some Buddhist ideas. People who are nominally Jewish may have some New Age ideas and their own perceptions of health and ideas. And so this tremendous diversity from bed to bed, from examining room to examining room, this person's Roman Catholic and this person's... how can healthcare people assess the spiritual health of people with such a breadth of beliefs and ideas? Maybe we're better off just ignoring and pretending they're not there. So is it too much to expect me to know the viewpoints and ideas of each person I see? And what if the physician or the caregiver is non-religious? What if they're not a believer in any sort? Are they supposed to be able to assess and manage these spiritual things that are so far outside their personal experience and belief that it becomes a challenge? Spirituality is a difficult thing to define, and it's defined differently by people in and out of different groups. But if it has a recognition of the ultimate other, a higher power in the 12-step organizations, or God in people who explicitly call him God, then we do have at least a bit of cultural understanding that there may be a fundamental role. The 12-step programs have their problems, but they have been highly successful for 75 years in helping people beat different kinds of addictions, alcoholism and others. And so with that, and inherent in that was the idea of a power greater than themselves. There's something transcendent, something beyond the immediacy. So it's not a bootstrap approach to getting better. You just got to get tough and work harder. That's been criticized in some corners, but I believe it is an element at least pointing toward a spiritual dimension. There needs to be a distinction between religion and spirituality, and that becomes hard to do, and I'm not here to try to give a definitive statement in that idea. But this is the way that might be a start toward that. A particular religion or faith community is one road to spiritual awareness and growth. And so spirituality in this sense can transcend a particular religion, and it resides in that human space where we seek to understand meaning and purpose in our lives. For some of us, meaning and purpose is immediately related to a hereafter, anticipated of an eternity. And meaning in hereafter is that there is a good God and Creator, and He has expectations of us in terms of behavior and response. For others, it's more nebulous than that, but a spiritual health axis needs to recognize that it will come to us in different forms. And we can respect those differences without calling them or grading them in any sort of quality level. So spirituality implies self-conscious living, something beyond the immediate. And so there are religious people who aren't terribly spiritual, and there are spiritual people who aren't terribly religious. And we try to make at least an important distinction, because sometimes we've used those as synonyms. Is he spiritual? He goes to the First Christian Church. Might not necessarily reflect their worldview and their personal approach to health and wellness. There's a lot of research in spirituality and health. There is objective data. There are things that have been published and analyzed. There is not a lot of research, and this is a tangential statement, there's not a lot of research on prayer. There have been attempts to do randomized trials where this group of heart surgery patients is going to have someone pray for them, and this group is not, and we'll look at outcomes. And it's been a terrible statistical mess because there's not a good way to have a control that prevents somebody from praying for the other group, and there's not a good way... there's not a good way to impact that. So it's been a terrible mess, and it's probably untestable, but it certainly has not shown positive results. There's not been, a good study that says this proves this. What has been shown to the view of science and statistics, however, is that people who are told that they are being prayed for and people who are prayed with in person do better than those who are not. So the power of prayer, without getting deeply theological, may have its greatest impact, and that's a may with an underline and an italics and several footnotes, but may have its greatest impact by the communication that the prayer is going on and that it exists. That there may be a very critical horizontal impact of prayer that we can latch onto and believe is valuable. And it's saying that more than one person in this dyad or triad or relationship believes there's something transcendent and greater, that there is a social aspect to that to be important. So, what is the data? What are the research on spirituality as a distinction from our talk about prayer? So people who have regular spiritual practices tend to live longer. That can be proven. Patients who are spiritual utilize their beliefs in coping with illness, pain, and life stresses. They use less pain medicine. They have less distress, less readmissions to the hospital, all of those kinds of things that hospitals like to measure. Are we doing the right thing? Well, you can show this with spiritual engagement. Spiritual commitment tends to enhance recovery from illness and surgery. They get better faster. In the University of Pittsburgh, they took patients who had had heart transplants, and they looked at how they did in the year or two after the transplant. So people who had regular religious activities and who had said prospectively that their beliefs and their faith were important to them, they had better compliance. They showed up to the clinic. They had better physical functioning when they tested their ability to run on treadmills and those kinds of things. And they had higher levels of self-esteem. They were happier with their recovery and their life circumstances. They had less anxiety, less prescriptions for anxiety, and less worry. The only difference in these groups, and this is not randomized, but it's the people who said, yes, faith and spirit is important to me. I go to church 3 times a week, or whatever their measures were. They did better. In a little bit of a translational research, in people who had measuring something called IL-6. So IL-6 is an interleukin. It's part of a very complex system that drives medical students crazy of different compounds that interact with one another. And so IL-6 is associated with increased incidence of disease and is sort of a marker that things aren't right with inflammation and the immune system in the body. And so people who attended church were half as likely to have elevated levels of IL-6 as the people who didn't. And there's a hypothesis that regular religious commitment may improve stress control by giving us better coping mechanisms, better support in a social circumstance, that the strength of personal values and worldview, how you perceive the insults, the slings and arrows of the world are different. And it may be a mechanism for the increased mortality observed in other studies. In other words, this may be a key differential in one group or another, is that religious engagement and involvement. So if I were a heart transplant doctor, I'd be kind of stupid not to ask questions about spiritual involvement and engagement of my patients. If I'm going to ask, are you still smoking? Have you been exercising? Are you taking your pills? Asking about spiritual engagement would seem to be a critical dynamic of that. And I don't even have to provide any value statement with that. It's a simple question. What's important to you? Are you engaged in a spiritual community? And now I have a piece of information about the health of my patient. Patients in hospice in Burlington, Vermont, their spiritual beliefs were correlated with diminished pain. They needed less pain medicine than the people who didn't have that. They handled the circumstances better. Increased life satisfaction, greater happiness. And these are people who are very sick. They're at the end of life. In American Pain Society questionnaire to patients in the hospital, that column didn't work out, but you can figure it out. So personal prayer was the most commonly used non-drug method for pain management. So pain pills was first, and then prayer, and then IV pain medicines and relaxation, touch, massage. People are already pursuing prayer and spiritual dynamics for times when they're in pain. And we've seen in the other studies that it actually works, that people have less pain and less needs for these other interventions. In a bereavement setting, parents of children who had died of cancer followed up for the following year. 80% said that they received significant comfort from their religious beliefs at a point in time a year after that death. They still perceived that as comfort. And parents had better physiologic and emotional adjustment. You may know this, but parents who have a child die of cancer have about a 30% divorce rate over the next 2 years, and it's about a 55% divorce rate over the next 5 years. That's an incredible stressor on whatever the relationship might be, having a child that's horribly sick and dies. And so people who had a spiritual component to their life and lifestyle were doing better than those who didn't. And 40% of those said their own religious commitment was actually stronger after the death of the child than it was before. So did that mean they didn't question God's goodness? I didn't say that at all. But it says that over time, many of them found that things were improved in their own personal assessment of spiritual strength. There was a study of 108 women who were having treatment for gynecologic cancers like cervical cancer and endometrial cancer, and they asked them, what helps you cope with your cancer? So 93% said, my spiritual beliefs do. And 73% or 75% said their religion was a significant place in their life, and almost half said they became more spiritual after their diagnosis. This is a component of the people we're seeing in clinic, the people we're meeting. There's something different about their lives that if we're asking merely about the biological or the vaguely psychological, we're missing out on. HIV-positive patients at Yale, not everyone can go to Harvard, so some people have to go to Yale. There were 90 HIV-positive patients that were surveyed about their fear of death. So people who are spiritual had less fear, less death, better CD4 counts, lower viral loads, and things that we can measure along the way. So, in a Gallup poll, these are people who are dying. 82% said that what was important to them, what gave them reassurance in their end-of-life event, what gave them meaning, was that they had given or received blessings that were important, that they counted themselves blessed, and they perceived them to have been a blessing to other people. This was meaning in a time of end of life. 76% believed that they had made your mark on the world. Now that's a personal assessment, but it has a spiritual component. And over half said that just knowing that prayers were prayed for them, and in some religious traditions after their death, prayers would be prayed for them, gave them meaning. It meant that this end of life had a different perception for them. Believing that you would be eventually in the loving presence of God, believing that death is not the end of their existence, but a passage to a different existence. Believing that part of you will live on through your children and descendants, which is a little different than the other, but it's still an idea of an ongoing presence. And feeling you are reconciled with those you have hurt who have hurt you. Again, I mentioned last night, reconciliation and forgiveness are critical aspects of pastoral care and health care. It's a rich topic that I encourage you to look into further. So, spiritual history. If these are important, if understanding the spiritual dynamics of someone is something we're going to agree that we ought to at least assess because of data and because of good common sense, how are we going to do that? So it has to be dynamic. It's not going to be the same from day to day. It's not a fixed thing where we check Southern Baptist and now we've done the spiritual history. That's what we do sometimes. But what's going on when the illness or the disease changes? Oops, that was fun. And the circumstances are different. Religious convictions may affect healthcare decision making, and you won't know if you don't ask why someone's choosing to do what they're doing. There may be a patient need. This may be something they desire and they don't know where to access it, where to bring it up, who to talk to about it. And if we don't ask, they won't volunteer it. It may be important in patient coping, and most important, it's integral to whole patient care if we're really going to treat the whole patient. Positive coping, people who had positive coping had less distress. Forgiveness and trying to forgive others was important to them. They found strength and support. Negative coping, people who had poor spiritual dimensions had more depression, poorer quality of life. They were more callous toward others. And so they were unable to resolve anger issues sometimes. And anger and forgiveness are related. So what do patients nearing the end of life say about spiritual dimensions or about those aspects? Well, they have fears. Naturally, they fear uncontrolled pain from whatever their disease process is. They worry about becoming a burden on their family. That's a very common one I discuss. They're concerned about the financial costs of care. That's very real. They say, well, if I die, it's not so bad, Doc, but if I leave my wife bankrupt, I've not been a very good husband to her. Uncertainty about the dying process, what's going to happen to me, how will I feel? Anxious anticipation of whatever the ultimate end is. And they have concern for the unfinished business of life. I didn't get my kids quite raised, or my daughter's not married yet, or I really hope to see my grandson graduate. So patients raise spiritual questions. Who am I now that I'm sick or dying? Our self-definition changes. See, my self-definition is I'm a doctor, I'm a farmer, I'm a dad, and if I'm sick and in bed, am I any of those anymore in the same way that I was before? Your self-image changes when you're sick, and that's a spiritual dimension. What's the meaning of my life when I'm no longer productive and independent? Not merely what good am I, but what role do I have to play in the world? Where am I connected to others who value and see me as a person of worth? This is where a spiritual congregation, a church family plays a role. What is my relationship to the Creator, and what do I now value most? What's my values now? Not when I'm healthy and happy, but what's important to me when the crisis comes. So patients may have coping mechanisms related to their beliefs. They may be supported by a community of caring of others. They may feel themselves to be in the company of the divine, and their spiritual values will affect all of their other choices. We have to ask to know. We have to ask to know. So it's a question of meaning. Epictetus says it's not important what happens to a person as the meaning the person gives to what has happened. And I believe that assignment of meaning is essentially a spiritual function. There's not a biopsy for it. There's not a blood test for it. It's a spiritual function. So meaning is related to purpose, and so some questions might be, why do you think you have become ill now? Has this illness changed any attitudes you might have about the future? Is there anything more important to you than regaining your health? It's not a question we often ask. What's more important to you? It's not living as long as possible, but having some resolution, having some peace, providing for my family. How does this illness interfere with your goals in life? What purpose is served in regaining health? So those are questions that would be hard to ask. A favorite author of mine is Viktor Frankl. Frankl was a neurologist, psychiatrist from Austria. When the Anschluss happened and Nazi Germany took over Austria, co-opted that nation, he became a subject of the Nazi regime. He was Jewish and a physician. And after a brief period of practicing in a very limited type of medicine, he found himself sent away to concentration camps. First to Auschwitz, later to Dachau, and his wife was sent to Bergen-Belsen. He survived that, but he saw many people who didn't, and in his response, the rest of his life as a man who had worked around people who were suicidal, people who had lost hope, people who could not assign meaning to this horrible, meaningless slaughter of human beings all around them, this horrible inhumanity of man to man that's not been equaled in our recent memory. So he said that at times, external circumstances in our life are beyond our control. In fact, that's an often. We like to pretend that it's not often, but it is. But he says that the attitude we choose to take is within our control, and what he would not entirely call a spiritual journey, but I think that it's an appropriate commentary on what his approach is, that it relates to our inner struggle to shape our attitude toward illness and even to death itself. So what is that attitude? So he said that the will toward meaning, having meaning, had an aesthetic. We might find meaning in beauty, in creation, and in created art. It was relational, meaning in relationships with others, family, friends, church. It might be creative, and we encourage a number of people who are in stressful situations to play music, to draw, to do things that are artful, write poems. And it might be attitudinal. So we shape the attitude toward illness and death in that crisis. So what do doctors do with this information? People need meaning. There's value in spiritual circumstances. 43% of physicians affirm that they pray for their patients. 90% of family doctors agree that a patient's spiritual beliefs can be helpful, and 58% have actively pursued information on spirituality and healing for their own interest or on behalf of patients. It's not that rare. It's not that uncommon. It's not an other in terms of relationships. In USA Weekend and Faith poll, patients said 65% said it was good for their doctor to talk about their spiritual beliefs. So many of us are sort of afraid to do that because we don't want to offend, but the other side of the room is we would like to talk about these. But only 10% said a doctor had taught them about spiritual faith ever. So doctors are praying for their patients, they're concerned about them, but they're not talking about it, at least in the numbers we would like. University of Pennsylvania study of people with bad lung disease, 2/3 said that a physician's inquiry would strengthen their trust in the physician. They wouldn't think he was a strange person. They wouldn't think she was prying too deep, that they would say, yeah, I trust them more because they're looking at me as a whole person. And 94% of patients for whom spirituality was already important wanted their physicians to address those. They were begging for it to happen. And so spirituality, even in 50% of those for whom spirituality was not important, wouldn't be offended. Now 50-50 is not a great odds, but it's not a universal rejection of the discussion. And only 15% said they recalled having ever been asked whether their spiritual beliefs would influence their medical decisions. That's going to be hard to read. Take this on faith, that there are a number of attitudes and formal settings that are now encouraging spiritual health dimensions. So spiritual care, that practice of compassionate presence that we discussed last night, is critical. We need to be attuned to listening to patients' fears and hopes and pains. We need to obtain a spiritual history. We need to be attentive to all of the dimensions of the patient's health. We need to incorporate spiritual practices, rituals, whether that be communion and prayer and laying on of hands, things of that sort as part of that. And that chaplains are really critical members of the interdisciplinary healthcare team. So we have goals in the curriculum for our medical students at East Tennessee State University that says they need to be aware of spiritual health. They're going to be able to elicit a spiritual history from a patient. Our learning objectives are going to realize that spirituality has direct impact on health and health outcomes, and that understanding the caregiver's own spirituality is going to be a step to be able to nurture, encourage, and be comfortable with those discussions. We need to sort of reconcile that with ourselves, at least at some level. And so we need to make those appropriate referrals. The Joint Commission, our big brother Orwellian organization that accredits hospitals, says we have to ask about spiritual health. And if you don't do that, you're not a good hospital system. The American Psychiatric Association says physicians need to obtain information, but they shouldn't impose their own religious beliefs. It's not time to proselytize, but it's time to communicate. And the American College of Physicians says that physicians should extend their care for those with serious medical illness by attentiveness to biopsychosocial, existential, or spiritual suffering. And it's sometimes that existential and spiritual suffering that is the most critical and the most painful. About 2/3 of U.S. medical schools teach something about spirituality and health, although the degree to which they teach is limited in some cases. And in my own borrowing from the Foster's publication, Religion and Medicine, there are 6 requirements for a physician to meet the spiritual needs of a patient. First of all, be trustworthy. Don't violate the trust of that discussion. Be unflinchingly accepting, even when what they tell you sounds strange, or if it's not what you expected to hear. It doesn't mean that you endorse it, but accept it, hear it, and acknowledge that that's what they believe. Treat the patient as a person, to be kind, to maintain hope, and to assist the patient in determining what it means to live. Those are tall order. Those are difficult things, but critical for us to be the things we would. I'm going to skip a few slides here in the interest of time, that we have some instructions for medical students, and if those of you have interest in those later on, how to take a spiritual history. So we have a little acronym to assess spiritual belief system, personal spirituality, integration into a spiritual community, ritualized practices or restrictions, things they forbid and don't allow to do, the implications for healthcare, and then sometimes spiritual dimension of terminal events like planning for the end of life. And so we have a little memory mnemonic for that. St. Joseph's Hospice in London was one of the first modern hospice circumstances, not the only, but a critical one. It says the aim of care for the dying patient is to make the body comfortable to live in so that the patient can prepare for death mentally and spiritually. And I think that is a guiding principle for even people who aren't necessarily imminently dying, that our goal in treating the body is not, let's keep the body going as possible, but to keep this vessel that some important metaphor calls jars of clay, this body going so that the greater implications and decisions of our existence can be made. So health is merely a means toward those greater questions of our existence. In looking at a biopsychosocial spiritual model, I would encourage the health caregivers in the room to begin to formulate a way. How am I going to ask these questions? And what am I going to say when the answers come back? How will I use that by showing regard and kindness? And to understand that that is a critical dynamic. For those of you who aren't health caregivers, you can be tremendous assistance to us in translating and interpreting and helping to draw out those kinds of issues that they may not be as comfortable volunteering. Although I'll tell you that they'll sometimes tell their nurse and doctor things they won't tell their pastor because they're a little bit more worried what their pastor thinks about them and what they believe. And if they're certainly not in the orthodoxy of your denomination or your group with their personal idiosyncratic belief system, then they might not volunteer that to the people in their faith community for fear of being labeled heretical or strange or getting a Bible lesson and several tracts that follow. But they may volunteer that to someone outside their faith community, and so a dialogue in that circumstances is critical. I hope that our time over the week has been valuable to you. I hope that we've at least asked questions that you'll begin to seek answers for, that we've created an enveloping circle of people that overlaps and intersects in ways that we can continue a critical dialogue on the roles that spirit and health play in medicine. And I thank you for your attention and your time this week.